Next is about the diseases of the anal canal. Now, before going into the diseases, a bit about the physiology of defecation. Now, defecation as such is a very complex mechanism of the physiological activity, primarily in the lower animals as well as in the newborn in the younger age. It's a purely involuntary function, but later on the same would be overridden by a voluntary control over the involuntary function. It's not totally involuntary as well as voluntary. Moreover, the structure of the anal canal is such a complex structure that no technology can mimic it. It's a tube, patent tube, which always remains patent. There is no wall, but it can be airtight. It can allow even a solid substance or selectively air only to pass through without having a wall, and no technology till now has devised such a tool till now, and hence we can say that all that scientific development, technological development is almost equal to the anus of the human being. So anyway, not even equal to the anus of the human beings. Now, how this complex mechanism is maintained, of course, it's a very detailed issue. I will be trying to make it as brief as possible, related to only the applied pathology point of view. From the point of view of the study of functions of the anal canal, the anal canal can be divided into two segments, the functional canal and anatomical canal. The functional also is called as surgical canal. Surgical canal is about 4 cm long and extends from the anal verge to intersphincteric groove distally to the anal ring. Now, this much of the area is what we call as the surgical canal, and the area below the dentate plane up to the anal verge is also called as the anatomical anal canal. The importance of this differentiation is mainly to study the functions, like the actual function of control of the defecation is more dependent on the surgical anal canal, and whenever there is any abnormality of the structures of the surgical anal canal, then you will have the abnormalities of the continence. The patient may have incontinence, or maybe there could be even abnormal continence. Anatomical anal canal helps only in the dilatation and allows the passage of the stools. It's just keeping the passage open and keeping the passage somewhat closed, like we have Savarjini and the Pravahani, the three stages or three levels of the anal canal described in Sushruta. The same is true. Now, Pravahani, Visarjani, Sambarani, the three functions, they are really the three layers of the functions. Like now, Visarjani and Sambarani. Sambarani is the anatomical anal canal. Visarjani is the surgical anal canal. Pravahani is something beyond that, where you have the voluntary component as such. Now, these three components, mainly the sphincters, the internal sphincters and the external sphincters, they do maintain that tone as such. Functions as such, in brief, can be described as or the whole act of defecation can be described as a complex mechanism involves the multiple organs. Colon, of course, it helps in maintenance of the consistency of the stools, and it has two types of the movement. The movement which is propels the stools towards the rectum, as well as there is a retrograde cyclic movement which can help in keeping the stools in the colon for a longer duration, so that it can absorb water and consistency can be made to a solid structure like. Then comes the rectosigmoid junction. Rectosigmoid junction acts as a sphincter. Acts as a sphincter like, which allows the substances to get into the sigmoid colon from the sigmoid colon to the rectum at regular intervals, or it controls that, and it gives a reflex of keeping it tight, so that the pressure in the rectum is maintained at an optimum level. If the pressure goes beyond a certain limit, you will have an urge for defecation. So that beginning of the urge for defecation starts at the rectosigmoidal junction and sensors over there. Then the rectum as such, it acts as a storage. It keeps the stools stored, and there you have the two forms of the movement, one the retrograde movement and then of course the propulsive movement. Retrograde movement occurs at an interval of around 4 movements in a minute, and the propulsive movement only starts when there is a urge for defecation. So urge for defecation is initiated when there is a propulsive movement or propagating movement as such. Retrograde movement helps in sensing the pressure within the rectum, and whenever the pressure goes beyond a certain limit, it reaches the higher centers through the nerves, and that nerve pathway, you will be just referring to that part. So and it keeps the sensation, it initiates the sensations of the defecation in the area due to the rectum, there is pressure over there, and keeps it compliance. Compliance since the pressure is not built up rapidly. See, there could be addition of the volume of the fecal material, but the pressure would not build up rapidly in the normal situation. There is the capacity increases, rectum capacity increases as the substance stools get added to the rectum, and keeps the pressure at an optimum level. That's what we call as resting pressure. Then the puborectalis muscle, the outside one, which is a really voluntary component, which helps in straining as well as retaining. It's a voluntary contraction at your will. You can either hold on, or you can strain, so that the movement of the stools are facilitated. In the anal canal as such, it's a distensible structure, and it actually helps in maintenance of the pressure by retrograde movements, retrograde as well as propulsive movements as such. Internal sphincter is one of the important structure which has an involuntary mechanism. See, there are two sets of the sphincters, internal and external sphincters. The internal sphincters are totally involuntary, and they keep the rectoanal inhibitory reflexes, so that there will not be any sudden urge for defecation. So as far as the continence is concerned, continence is keeping the stools closed, samvarana kriya. That's done by the internal sphincter mainly. Whereas the external sphincters, they keep the resting pressure at an optimum level, and they help in inducing the squeezing pressure, that whenever there is a contraction, that's a urge for defecation, it can squeeze, and this can help in either keeping the anus closed or keeping the anus open depending upon the requirement. And it also is facilitating, that squeezing is facilitated or prevents the recurrence, prevents the leakage, like if there is a sudden increase in the pressure, like a cuffing reflex, or if there is any painful stimulus, or any sudden changes in the pressure in the abdomen, doesn't allow the stools to pass through immediately. Leakage is prevented by the external sphincter mainly. Then the anal cushion is the other soft structures of the anus, the fat and other tissues, vascular blood vessels over there. They again help in maintenance of the resting pressure to a certain extent, and it mainly the major function is to keep the resting pressure at an optimum level. Any irritation at this area, like kinesias, itching, or some oozing over the area, can produce more squeezing pressure, and the anus can become more constricted. And of course, the anal gluteus muscles also help in the defecation as such. Now, internal and external sphincters are the two important structures. Internal sphincter, as we have discussed, it's a smooth muscle, and it's having an involuntary control, and the resting tone of the rectum is maintained mainly by the internal sphincter. By about 85% of that would be contributed by the internal sphincter, and prevents the leakage. And it's the reflex response. If there is any sudden stimulus, internal sphincter relaxes, and the defect of the internal sphincter can result in passive sagging, or what we call as incontinence. Whereas the external sphincter is a striated muscle and innervated by the pudendal nerve under the voluntary control, and can exercise and strengthen the sphincter, anal sphincter exercises, etc. External sphincter contributes around 15% of the resting tone, and when the stool is present in the rectum, there is an increase in the activity of the external sphincter, so that it gets tightened and prevents the leakage. And defect of the external sphincters can cause urgency for the defecation. So, whenever a patient complains of incontinence of the stools, there could be of two varieties of the incontinence complaint. where there is a soiling or real leakage, and the other is when the patient has an urgency for defecation and cannot sustain. A patient who cannot sustain the urge for defecation, there is an abnormality of the external sphincter, and that can be trained, that can be managed with counseling and training and so on, because it's mainly controlled by the voluntary structures. Whereas a leakage, a continuous leakage, is due to the defect of the internal sphincter and cannot be managed with those. Now, the defecation reflexes. The defecation actually starts with some reflex activity or the sensations felt, and then you have the sequence of the events which occur. Defecation reflexes are mainly categorized into two categories: the intrinsic defecation reflex and the parasympathetic defecation reflex. Parasympathetic defecation reflex is purely autonomic, and it's mainly mediated through the fibers of the pelvic nerves. That's whenever the pressure increases beyond 40 centimeters of water in the rectum, that produces an urge for defecation, or that produces impulses, and those impulses reach to the hair center, which make a feeling like there is a rectum full, and then you have you know that there is a need for going for defecation. In the early childhood, it's the only parasympathetic defecation reflexes maintain the defecation act, and hence it's involuntary. But later on, due to the learning process, and which is considered to be the most difficult method or the most difficult technique of learning, is the control of micturition and control of defecation. So usually we say that those who have learned to control the act of defecation and micturition, they can learn anything. Studying Ayurveda or medicine is not at all difficult if you have learned the technique of defecation, controlling of the defecation and micturition. And anyway, so that involuntary phase starts with the parasympathetic activity, and then in the adult or in the later on, it's actually controlled by the intrinsic defecation reflexes, which are mainly by the main plexus, where it starts with the minor reflexes as such. And these reflexes which are produced, they will be reaching to through the spinal cord to the higher center for the cerebral cortex. And in the cerebral cortex, the whole thing is when there is entry of pieces by mass movement, rectum becomes distended, sensory nerve endings are stimulated, and these stimuli will be passing through the efferent and efferent nerves, and then once the cortex regulates it, then through the pudendal nerve there will be a stimulation for the voluntary structures, that the external sphincters as well as the other muscles, the pelvic floor muscles and abdominal muscles to contract, and that's how the act of defecation occurs. Now the act of defecation is mainly, again, in addition to these mechanisms, the puborectalis muscle acts as a sling which keeps the anus curved so that there will not be any sudden leakage of the stools. So even if there is an act of defecation or an urge for defecation starts, it doesn't go out immediately, because as long as the puborectalis muscle relaxes and keeps the anus widened and the structure of the anus is straightened, the stool muscles would not fall through. So you will have still some time to manage to prevent the leakage. Now again, the puborectalis muscle also is under the voluntary control, and there is a need for synergistic activity. The whole of these mechanisms need a synergistic activity of that involuntary to the voluntary level, and if there is any missing link in this maintenance of the link sequence of events, there can be the dyssynergia. So that's one aspect of maintenance of defecation. So naturally, another issue is of course not directly related to the pathology. To facilitate that kind of an angular movement, the position of this defecation, the commode, Western style of commode, Indian style of defecation, which is better? Obviously, there is a definite advantage of the Indian style commode or Indian style of defecation, where a squat, Kukutasana is done, and the puborectalis muscle relaxes much better in the squatting position than the Western position. Of course, this is not the important issue of physiology, but a matter of interest, and now this is well studied, well known, and those who are considering that Western commode as a fashionable and maybe more modern and so on, whatever that awe about Western model, it's not really helping the physiology. That's the point. Now, another aspect of the act of defecation is the regulations of the pressures. The pressure in the rectum would be always in the resting condition would be lesser than that of the anal pressure. In the resting pressure, the anal pressure, the pressure at the anus level is around 60 to 70 millimeters of mercury, and the pressure in the rectum would be much lesser than that. When the pressure builds up in the anus, in the rectum area, beyond a limit of around 90 to 100 millimeters of mercury, there would be a urge for defecation, and that urge for defecation starts in, which produces what we call as the squeezing pressure, and that squeezing pressure is when there is a real act of defecation, and there the pressure can increase up to 170 millimeters of mercury, almost around the two-thirds of the resting pressure. Now, if the pressure raises, that pressure gradient between the two, anus and the rectum, as long as the pressure gradient between the anus and the rectum is around 40 to 50 millimeters of mercury, there will be no leakage of air or no leakage of fecal material. When the pressure goes up to a level of around 14 to 16 millimeters of mercury, air only passes through, then you can pass the flatus. When the pressure gradient reverses and then the anal pressure reduces and the pressure in the rectum is increased to 127 to 170 and the anal pressure becomes zero, anus relaxes, then the stools pass through. Now, if there is this sequence of events again can somewhat miss as such, so if the pressure doesn't get reduced during the act of defecation or so on, that produces what we call as a dyssynergia. Dyssynergia we have already discussed as such in the chapter related to the hemorrhoids and so on, maybe. But again, the dyssynergia are again of four types as such. The normal would be in the rectal pressure during the defecation when there is a squeezing, the anal rectal pressure increases and the anal pressure reduces. Now, this can be easily felt by a methodical digital examination. Once you put in the finger into the rectum, if you ask the patient to defecate or squeeze, you will feel that difference. The base of the finger would be having relaxation and tip of the finger feel that the increased pressure. If it is altered, then you will have the different types of the dyssynergias. Among them, the type 1 dyssynergia is during the squeezing, instead of the pressure, anal pressure getting reduced, the anal pressure also increases, rectal pressure also increases. This makes the patient unable to pass the stools easily. Type 2 is when the rectal pressure doesn't increase and the anal pressure increases during the squeezing, which is almost a reverse of the normal. That also will be producing a situation where the patient takes more time for the act of defecation or the defecation would not be complete. It's another part of the dyssynergia. And these issues we have discussed when we have discussed about the constipation earlier in the earlier discussions as such. Type 3 is where the rectal pressure increases but the anal pressure remains low and it doesn't respond as such. So that patient would have an increased frequency of defecation. Type 4 is both the pressures are lower, which often occurs in the neurological patients as such. So there are four types of the dyssynergia which are identified. These pressure variations can be easily felt by a simple digital examination, but still there are many objective investigation tools which are a bit costly and which are laborious. Among those objective tools is one is a defecogram. Defecogram is a contrast X-ray where you can take the image during the act of defecation, which gives you an idea about the position of the anus and rectum and the puborectalis muscle relaxation. Whether the angle changes. In the resting condition, there will be an angle, and during the defecation, that angle reduces, and based upon that, some of these dyssynergic mechanism can be identified as such. And of course, another investigation is anal manometry. Anal manometry, which also is now sophisticated one. Now, my purpose of referring to these investigations is not that every patient requires it, and I would say that you won't need those investigations at all. You can manage these or identify these abnormalities by careful digital examination. But you should be aware of these investigations. If a patient comes with the investigation tools, you should not override, so you should know exactly what it means. Anyway, that's about the very brief about the basics of the physiology of defecation. Now we start with certain of the diseases which are related to these. One disease is about the constipation. Constipation we have already discussed when we discussed about the intestinal pathologies in the earlier session. Now, another important condition which is related to these abnormalities of the tones of muscles and this mechanism of the relaxation and contraction of the muscle is the anal fissure. Anal fissure is defined as a boat-shaped ulcer over the anal margin, and the causes could be many. But important abnormality is the hypertonicity and hypertrophy of the internal anal sphincter. In patients of almost all patients of anal fissures would have a increased tone of the internal sphincter, or a increased thickness or hypertrophy of the internal sphincter, which could be either a cause of the disease or at times it could be a result of the disease. It could be having both cause and effect relationship. Like a patient who has a wound in the anal canal due to some friction of the stools or other reasons, or like purpurium where the stretching of the this rectum can result in a wound, can result in hypertonicity. Tone of the muscle, sphincter could be increased as a result of the painful stimulus over there. Or it's the other way, a basic pathology of the tone of the muscle, this internal sphincter, can be a cause for the fissures. In anyway, both the conditions, the important issue is about the abnormalities of the tone of the internal sphincter, which need to be tackled as such. Now, causes are many. The most important cause is the bowel habits, abnormal bowel habits. A patient having a constipation who has to strain either during the bowel movements or during the childbirth. So, when the patient has a constipation and then the defecation, abnormality of the defecation results in the fissure, is usually in the posterior side of the rectum, anus, that the fissure should occur. See, that's when the stools are pressed down, hard stools are pressed down, the maximum pressure would be over the posterior surface, and hence the posterior midline fissures are common when it is due to the straining of the fecal material or constipation. Whereas a patient who has a abnormality produces the straining due to the childbirth, because during childbirth the perineum would be distended, and that distension of the perineum may produce a mild tear over the anal margin, and it's always in the anterior midline. So most of the times what happens is a male patients would have the lesions over the posterior midline, whereas the females, they would have the lesions in the anterior midline. And almost as a rule, a fissures having in the anterior or the posterior midline are produced due to the straining, either straining due to the defecation or straining during the childbirth or so on. So there your target of the treatment would be towards avoiding that straining activity. Now, the other causes of the fissures could be inflammatory bowel disease like Crohn's disease, or abnormality of the blood flow to the area, or simply overly tight spastic anal sphincter muscles, which are maybe the other genetic origin conditions. In these conditions, the position of the fissure may not be predictable. See, I told you, like either it's anterior or the posterior midline fissures, the cause is certain, like it's due to the straining, and straining could be due to any of those causes, like either abnormal bowel movements, childbirth, or occasionally patients who have a urinary pathology also, that straining could be a cause for the fissures. When the fissures are seen in the directions or locations other than of the midline, anterior and the posterior midline, then you have to think of the other causes, and the other causes like intestinal pathologies. It could be ulcerative colitis, Crohn's disease, etc., or some ischemic pathologies over the area, or maybe the simply genetic pathologies where the sphincter has become tightened, or as such hypertonic sphincters tend to occur. The other conditions which can also present in the fissure, which need to be ruled out before you conclude that it's anal fissure, are anal cancers, HIV also can present with the lesions in the anal area, tuberculosis, syphilis, and herpes. In these conditions too, the ulcer would not be having that typical boat-shaped ulcer. The shapes could be different. In anal cancer, there could be multiple lesions which are indurated. HIV infected conditions, multiple scar-like, irregular scars-like features could be seen. Tubercular ulcers would be having that inverted edges. Syphilis would be very wide and superficial, these flat ulcers. Herpes would have multiple eruptions and so on. So the differences have to be made out by simply looking at the lesion, examination of the lesion. A typical fissure when you have stretched the anus can be seen as a boat-shaped longitudinally situated ulcer, and that's exactly how you can make out a anal fissure, which needs to be differentiated from the other conditions by simply the gross appearance in many situations. Of course, if at all there is any doubt, you may have to go for the investigations as such. The clinical presentation would be pain. Characteristically, the most important clinical symptom in all cases of the fissure is the pain, and it can be even severe, and characteristically it's produced during the bowel movements. Usually pain starts once the bowel movement starts, and the pain can last for a certain period of time, and very characteristically the pain stops abruptly after a certain period of time. The time is unpredictable. In some patients it could be a few minutes, in some patients it could be a few hours, but the pain starts during the defecation and pain continues for a certain period of time, then stops abruptly. Whereas the other conditions which can produce the pain in the anus area, they would have a different presentation. Proctitis, inflammatory pathologies of the rectum, that would start with the pain before the defecation, and the pain may last after the defecation for a certain period of time, and whenever there is a recession or when the pain is reduced, it will be a gradual reduction of the pain, not sudden. Whereas inflammatory pathologies like the abscesses in the anus area or other conditions, pain may not be directly related to the act of defecation. There could be constant pain, but during the act of defecation they may aggravate it. So if you take a correct history of the pain, many times the fissure can be easily diagnosed as such. Then the other clinical symptoms could be like when there is bleeding, and that bleeding would be characteristically present as a streaks over the stools. It's not mixed with the stools. Simple line-like appearance, and the quantity of the blood may not be quite huge. Usually small quantity of blood seen on the stool or toilet paper after the bowel movement. Then if you examine, you may see that crack, that visible crack on the skin around the anus, and that skin, as I told you about the shape of that crack, also gives you some idea about the possible cause. A linear shape, or what we call as a Kenny-shaped, boat-shaped ulcer, is characteristic of a fissure produced due to the straining activity. Whereas when the shapes are otherwise, you need to think of the other possibilities, rule out the other causes as such. Then a lump or the skin tag also may be produced. See, when the fissure is persisting for a long duration, that wound is there and doesn't heal completely, that produces a fibrous scar, and that scar may get projected through, and which is called as a sentinel tag, which may seem to be a pointed projection over there. Then pain after the bowel movements can last for hours as such. Now, in all these conditions, once you have made the diagnosis of fissure, the treatment goal would be to relieve the constipation and break the cycle of hard bowel movements as such. So that's the primary consideration in the treatment. And the majority of the patients can manage it with simply that bowel regulatory materials. Softer bowel movements are easier and less painful. That's the usual mechanism of the principle of the treatment of giving bulk relaxants. Now, if these are not enough, then the management would be the other options which are available in the contemporary would be applied nitroglycerin. Nitroglycerin is a muscle relaxant and keeps the muscles relaxed. Or topical anesthetic creams like lignocaine jelly also can be often used. Another often tried is a Botox injection, which also keeps the muscle relaxed. Then nifedipine, they also can be tried. These are the other options which are available in the contemporary system. If this conservative management doesn't succeed, then the interventional treatment is suggested. Interventional treatment would be sphincter dilatation or fissurectomy or internal sphincterotomy. Now, compared to all these descriptions, If you look at the description of the Vataja Arshas in Sushruta, that's exactly the same, where the lesion would be like Kadamba Pushpa Tundikeri Nadi Mukala Suchi Mukha Kritini. That's a typical presentation of a sentinel tag, where there would be a lesion which is seen as it. Then a wound would be Parishush Karuna Vivaranani Vishama Madhyani, where the middle area of the wound is depressed, that's boat shaped or kidney shaped wound, and the patient would have constipation, Sasulam Samhata Mukveshade, constipated bowels, and the pain would be in the pelvic region and Kati Budalabha Pradesh such as Bedana. Now, I would be treating the patients of Fishery Neno either with Gandakarasana, Chitrakati, and Manipatra Buddha or Avipatika Rajuna, depending upon the presentation. And almost 99% of the fissures can be managed with this treatment, and I can swear that these treatments are much better than any of those other local applications like nitroglycerin or maybe the local anesthetics even. So that's what we can do. Only in those patients where the medicine may not respond, then we may go for the surgical intervention. Surgical interventions would be, the simplest would be the Lord's dilatation, where you keep 4 fingers in and then stretch the anal opening wide, so that there will be a tear of the internal sphincter. Once the internal sphincter is torn, the tone of the muscles will be retained, remained as such normal. But one precaution is, if the patient has a history of incontinence or leakage of the stools, better not to intervene. And this is very simple and easy procedure, which occasionally we may have to do in patients who do not respond to the medical treatment. The other alternative choices, which are now becoming popular and somewhat claim to be more efficient, but practically I don't say that they are very efficient, is and which somewhat called as sophisticated, is a internal sphincterotomy. The internal sphincterotomy procedure also is a simple procedure where you make a small incision or just prick a sharp needle, a sharp blade at the level of the internal sphincter and cut the internal sphincter without injuring the mucosa. The mucosa is kept intact, just insert the blade and bring out. Keep it as such. So that cuts the sphincters as such. Now, the claimed advantage of this is it produces a sharp and regulated cut, whereas when we see the large dilatation, as I have shown in the previous figure, the tear in the internal sphincter is irregular, and there is a claim that this sharp cut is more beneficial than the other way, but I don't agree with that, or maybe I have not observed much differences. And instead of going for this complex procedure where you have to, not very complex, but a blind procedure rather, there is a blind procedure. If at all your blade doesn't reach to the exact internal sphincter area, there is a possibility of having more complication, and other complication could be uncontrolled bleeding also can occur in this area, and hence a large dilatation is I consider as superior, but globally the other way, the guidelines, I will come to that guidelines. In the guidelines, it's considered to be more efficient. Another of the option is a fissurectomy, where the fissure is removed, tissue is removed and then sutured. Fissurectomy is preferred when you are not sure about the cause of the fissure and you want to have a tissue sample to be studied. So in such condition, you may remove the fissure tissue, send it for histopathology, so that the other lesions like tuberculosis, so one of the frequent issues which may have tuberculosis or at times malignancy. So to rule out that, you may go for the removal of the tissue and then suture the area. This also is another option, but I would limit this only to those conditions where your clinical diagnosis requires some support, histopathological support. In that condition, a fissurectomy could be treated. I referred to about the guideline. The latest guideline, which was released in 2021, is American Society of Colon Rectal Surgeons Clinical Practice Guidelines for the Management of Anal Fissures. I have just copied it as such. The 11 guidelines are there, and I have not added even a single word of mine there. It's direct copy. Non-operative treatment of acute anal fissure is safe and should typically be the first line of the treatment. Then anal fissures may be treated with the topical nitrates, although headache symptoms may limit their efficacy. Compared with the topical nitrates, the use of calcium channel blockers for chronic anal fissure has similar efficacy, like that's channel blockers are nifedipine-like drugs, with a superior side effect profile and can be used as first-line treatment. Botulinum toxin has a similar result compared with the topical therapies as first-line therapy for chronic anal fissures and modest improvement in healing rates as second-line therapy following failed treatment with the topical therapies. Lateral internal sphincterotomy may be offered in selected pharmacologically naive patients with chronic anal fissures. So there again, lateral internal sphincterotomy is considered as a better option in that guideline, and it's selected for those patients who do not respond to the other conservative treatment. And lateral internal sphincterotomy is the treatment of choice for chronic anal fissures in selected patients without baseline as such. Then open and close techniques, that's the fissurectomy, yield similar results, and either technique may be used, any of the technique may be used. So there is no specific advantage mentioned in the guideline. Then internal sphincterotomy is tailored to the length of the fissure, yields similar healing rates but decreased rates compared to the traditional internal sphincter extending to the dentate line. See, in the internal sphincterotomy, there are two options. One, you have to extend the lesion till the extent of the fissures, or extend the lesion up to the dentate line. And comparatively, it's said that the sphincterotomy incision done up to the length of the fissure is supposed to be more beneficial. Then short-term outcomes of repeated internal sphincterotomy or botulinum injection for recurrent anal fissure have shown good healing rates with the low risk of open one, but the data are limited. Anyway, addition of anocutaneous plaque to the botulinum toxin injection or internal sphincterotomy decrease postoperative pain and allow for primary wound healing. These are the guidelines. But from my point of view, all these guidelines are not very much significant. Our treatment with Gandhaka Rasayana and Kankayani could be the most important issue. And one of the important facts which you have to keep in mind whenever dealing with the fissures are the main contraindication of the surgery for anal fissure is impaired fecal continence. You have to take a detailed history about the fecal continence. If the patient has even a minor leaking of the stools, better not to go for any intervention, and the best of the treatment is a conservative treatment, because the incontinence may become more severe after a intervention, and that's about the fissure and fissure treatment. The next condition which we discuss about the anus would be anorectal abscess. Now, anorectal abscess, as in any case of the abscess, is produced due to the purulent pathology, infections which result in pus formation. And from the clinical point of view, as far as the internal issues are concerned, the location of these are important to help in making the diagnosis as well as to treat the conditions. The classification of these locations are based as perianal, which is around 60%. Majority of the patients are perianal. Then comes the istiorectal. The istiorectal is the perianal is just subcutaneous around the anus area and doesn't involve the sphincters, not very deep and usually small. Quantity of the pus is usually lesser. Istiorectal fossa has a huge fossa and lots of fat tissue is there, and there a huge amount of the pus could be accumulated, that constitutes around 20%. Intersphincteric is where the pus is formed in the space between the sphincters, which is often difficult to make the diagnosis. When these conditions will be often difficult to make the diagnosis. Supraelevator, where the pus is accumulated above the elevator muscle, often in the pelvic area, usually due to some consequence of the abdominal pathology, where the clinical presentation could be quite misleading, and again clinical diagnosis would be difficult. You have to make use of the investigational tools to make the diagnosis. That constitutes around 4%. Submucosal, just below the mucosa, is very rare and it's a very superficial one, which is around 1%. Now, differentiation of these by a clinical examination, by looking at also, is quite possible, and among them the quite important are the more frequent are perianal and istiorectal. See, 60% and 20%. 80% of the patients can be correctly identified by a simple clinical observation. A patient of perianal abscess would have a pus collection which doesn't result in the bulging of the perineal line. The perineal line would be intact and you can see the bulging only one side. Whereas in a ischiorectal abscess, when the pus is accumulated deep in, the perineal line would be either curved or maybe pushed apart as such. See, the midline, perineal line in the first image is straight. That suggests that it's a perineal. Whereas ischiorectal, because of the deep one, the perineal line would be bundled. So if you observe this, keen observation, you can make out whether it's ischiorectal or perineal abscess. Of course, that can also be made out by a digital examination, but what happens is in many of the patients that because of the acute pain, a digital examination may not be possible or may not allow that as such, and hence many times you may have to depend upon simply the clinical observation, and you have to, when go for the incision, you should be prepared for this. A perineal abscess can easily drain superficially by a simple incision, whereas ischiorectal fossa you have to have a deeper incision and the preparation has to be a bit more. So you should be prepared for that when you go for the drainage. Then intersphincteric is again could be of two categories, where the pus could be accumulated between the two sphincters, which may not be presented clinically as a bulging as till you feel the digital examination. Till you put the finger in, you cannot make out. Patient may have continuous pain, all the other features of the abscess like the fever and so on, but its swelling may not be seen on the exterior. But when you put the finger in, you may feel that tender mass in the sphincteric area, and again it could be of two categories, intersphincteric or outer sphincteric, outside the external sphincter or in between the internal and the external sphincter. That's the location, but these locations can be objectively made out by a MRI scan than really the clinical examination. So if at all you have to have a very objective diagnosis or you are not able to make out clinically, it's better that you go for a MRI, and that MRI can show the abscess location exactly as we have seen in the schematic diagram. The pus location in between the internal and external sphincters, where the external sphincter can be seen as a bulging one, whereas in a outer sphincteric area, the sphincter's muscle may not be visible. So MRI scan is a better tool to make the diagnosis in such conditions. Then supralevator abscess is a situation where the pus is formed above the levator muscle and often produced due to some pelvic issues, and that also can be better made out with either ultrasonography or MRI scan. The location of the pus can be made out, schematic diagram of the location of the pus. One of the important advantage of supralevator abscess, if it is accurate to diagnose, is it's a better route of drainage of this would be per rectum. Through the rectum, you can make a small opening and drain the abscess. Without much tissue damage and without much later complications, you can manage the patients of supralevator abscess if you have diagnosed abscess. Same is true with the intersphincteric abscesses also. They can be drained easily, but the difficulty is making the diagnosis. Now, in any of the cases of anorectal abscess, the complications are may result in fistula formations or sepsis or fecal incontinence. Rarely, malignancy also could be either the underlying pathology or a chronic abscess can also be considered as a precancerous condition, can result in pathology. In all the conditions, the main treatment would be drainage. So the pus has to be drained, and then whether the patient requires the antibiotic therapy or not, that depends upon total leukocyte count. If the total leukocyte count is more than 17,000, you may require antibiotic. Otherwise, you can manage without that. But if you just without drainage, if you try to manage the patients, there is always a high possibility of multiple tracts formed, and then there could be the fistula formation. A complex fistula may be formed. Now, the World Society of Emergency Surgery and American Association for the Surgery of Trauma has given a guideline, published a guideline in 2021, the latest of the guidelines there. So I have copied those guidelines as such, and those are: in patients with suspected anorectal abscess, a focused medical history and a complete physical examination, including digital rectal examination, are suggested. That's the one. So the digital rectal examination in a case of abscess would be quite painful, hence you have to be more careful about that pain. Otherwise, a pain in the anal area can produce a shock. In patients with suspected anorectal abscess, it is suggested that serum glucose, hemoglobin, etc. hemoglobin A1C and urine ketones should be checked to identify undetected diabetes mellitus. This is one of the important issues clinically. Many of the undetected diabetes mellitus patients can be confirmed with after they have a perianal abscess, like any of the anorectal abscess conditions. In patients with suspected anorectal abscess and signs of systemic infection or sepsis, I would add 17,000 leukocyte count. A complete blood count, serum, creatinine, and inflammatory markers like C-reactive protein are suggested. Investigations of these are suggested. In patients with suspected anorectal abscess, imaging investigations are suggested in case of atypical presentation, not in all patients. So imaging are not required in all patients. Atypical presentation and particularly supralevator abscess conditions or complex anal fistulae or Crohn's disease suspected, MRI or CT scans are considered to be better, or endosonography. See, sonography, the usual conventional sonography may fail to make the diagnosis. When you have a perianal probe or intrarenal endosonography, then the diagnosis can be better accurate. So many of the ultrasonologists may not have that probe, anal probe may not be there. So you have to decide about that. Then in patients with anorectal abscess, surgical approach with the incision and drainage is recommended. That's the best of the treatment, and the timing of the surgery based on the presence and severity of the sepsis. In fit immunocompetent patients with a small perianal abscess and no systemic signs of sepsis, outpatient management may be considered. So it can be considered as a simple procedure as such. Now, another usual technique is when you use a drainage, the wick is packing is there. Now, about the packing, as per the latest guideline, no recommendation can be made regarding the use of packing after drainage of an anorectal abscess. They do not recommend, but what I would recommend is, if the abscess is deeper, if it's a hysterectal abscess, packing is a must. In a perianal superficial abscess, packing is not necessary. In patients with the anorectal abscess and an obvious fistula, hysterotomy at the time of abscess drainage is suggested only in the case of a low fistula that doesn't involve the any sphincter muscles. Many times it happens like patients of fistula may have an abscess. So fistulotomy or fistula handling is done only in case of low anal fistula. If it is a high fistula and intersphincteric fistula, it's better that you do not go for the fistulotomy or fistulectomy at that moment. At that moment, just drain and keep the fistula also drained with a simple set-on or maybe Kshara. In patients with anorectal abscess and no obvious fistula, probing to search a possible fistula is not suggested. You are not supposed to search for the fistula when it is not obvious, so that there will be no complications. This is another of the frequent errors which the people do. Patients of hysterectal abscess, once you drain, usually people prefer to search for the tracts, but it's not recommended. That's another important issue. In patients with drained anorectal abscess, antibiotic administration is suggested in the presence of sepsis or surrounding soft tissue infection, or in the case of disturbed immune response. Otherwise, in a perianal abscess, usually antibiotics are not necessary. Then sampling of the drain pus is suggested. High risk patients, it's not necessary that every patient needs a assessment of the pus as such. Only in high risk patients. That's about the anorectal abscess. With that, we conclude today, and we continue with the fistula in the next session. So it's time up. If there are any questions, we'll try to answer and then wind up. There are some questions like, for chronic fissure in same medicine is applicable or different treatment? It's the same, whether chronic or acute. The medicine treatment which I prefer would be the same. Only in chronic fissures, there may be a need for dilatation if the patient doesn't respond to the treatment. Usually, I would try for about 1 to 2 weeks, like where we use Chitrakalli and where we use Triphaloguglo. There's another question. Chitrakalli is used when the patient has upper gastrointestinal tract symptoms like constipation or maybe irregular appetite. Triphaloguglo is preferred when there is a local swelling, nodular swelling or induration. Brana, that at the area of the fissure, if there is an induration, Triphaloguglo is preferred. And if the patient has more of GIT symptoms, it is the Chitrakalli is preferred. From our point of view, all the Arshas are produced with Agni-Mandya, and hence Chitrakalli is always a better option in patients. That's the one issue, right? With that, we will conclude today. Thank you.